from the biomarkers, of course.
So it's my pleasure and honor to introduce Dr. Ayesha Appa. She's an assistant professor in the Division of HIV, ID, and Global Medicine. She graduated from UCSF and treated internal medicine at the University of Washington, and did an ID, a joint, which is cool, joint ID and addiction medicine fellowship here at UCSF. Her work focuses on defining gaps in effective care for people with substance use disorders and who are living with HIV. Research is focused on implementation of models that provide simultaneous treatment of substance use disorders and HIV. She works clinically at Ward 86, providing HIV primary care, and also does addiction medicine, inpatient care at SFGH. Very excited to hear her talk. Combing through the data, what is the role of hair as a long-term biomarker of substance use in people living with HIV?
Thank you so much, Matt. I tried really hard to make this punny, so that there maybe less data and more combing or the other way around. I am really thrilled to be here today and open for Dr. Bob Cook, really, and thrilled to hear his about his work in contingency management. And wanted to, after sort of talking with my mentorship team, thought it would be a really lovely opportunity to combine this phenomenal sort of set of minds that work in biomarkers and work in substance use, and spend a little bit of time sort of introducing the shared world. So today I will introduce and talk a little bit about why measure substance use, which I think many of you all will be bought into, why hair, and then share a brief couple of studies. What have we done so far, and sort of where are we looking next? And I'll aim to finish in the next 15 minutes, and then get to Dr. Cook's talk. So why measure substance use? Again, many of you, I'm seeing some nods, many of you may be bought into this already. I think that one simple way of answering this question is by saying what gets measured gets managed. Peter Drucker may or may not have said this, according to him. My take on this, or sort of when applying this to our world, is what gets measured poorly gets managed poorly, or the flip side, which gets measured well gets managed well. And so it's really important that we measure substance use well and thoughtfully if we want to manage this well. I think taking that one side and bringing it out a little bit, sort of flushing that out a bit more, I think in years or decades past, we've had a recovery model of approaching addiction or substance use disorders, that it's something that people will recover from and never return to, or ideally, and as sort of an abstinence-focused frame that focus or centers relapse. And it's easy to use urine to sort of urine testing that's qualitative and yes, no really fits in well with that model. That as we expand our definition to sort of consider addiction as a chronic disease, and use that model in which we care a lot about reduced frequency or reduced quantity of use, or more days not using. What tools do we have to really understand those variables or those outcomes? I think an example of this is Phil Coffin and I gave HIV green rounds yesterday on managing methamphetamine use in people living with HIV. And, I think an illustrative slide that I'm borrowing from that is that the chronic disease model may be more meaningful than the overdose model that's so important in opioid use disorder or preventing fentanyl overdoses. And this is a study that Philip is running that is a psychological autopsy study and really reviewing in-depth cases of deaths that were due to stimulants. And this is an example of a person who is living with HIV who moved to San Francisco from the Midwest, really looking for support, and has found family used methamphetamine. That's what he started using too, and over the years developed congestive heart failure and chronic obstructive pulmonary disease. Ultimately was really functionally impaired, couldn't walk long distances and was found in his SRO deceased with methamphetamine on his toxicology. That was called acute methamphetamine poisoning. But I think the question is, was that really acute overdose, or was this manifestation of a chronic process that we could have intervened upon? And I think an example of this is, so if we take that person and that same sort of one-liner and imagine that this person was enrolled in an interventional trial to reduce use, and they were given a medication X or an intervention X, and he's able to reduce his use from daily to 3 times weekly and reduce, say, spending on his methamphetamine from $70 a week or $10 a day to about $10 a week. In our current model and many of our stimulant use disorder treatment trials, his urine testing that was positive at the intervention would say like, this is a failure. This intervention didn't work. When in reality, I think we both really want to know whether something was able to reduce use to this degree, and what that reduced use, like what its impact is on health outcomes, HIV outcomes. And so just like pausing to really like take in, I think the more time that I spend in the space around, what our outcomes are, the more it's like you start to see it everywhere. Like I think another topic that came up yesterday that we were talking about was reprieve. So a trial looking at giving statins to people living with HIV across different cardiovascular risk sort of categories, and finding benefit in a group that we wouldn't have traditionally offered a statin to in a lower risk group. And we don't know what role drug use or stimulant use played in this group. Like, what is that all driven by stimulants? We don't know. Maybe some degree of it. And so, similarly thinking about studies of HIV transmission, if often categories are sort of this generic PWID or PWUD, and we're not really getting granular. Again, measuring poorly translates to managing poorly. Just a lot of opportunity there. So that gets us, sort of moves us into why hair. And we could spend an hour or many hours on biomarkers of substance use, and hopefully we will in that with our subcohort in the future. But I think I'll just share this little cartoon as an outline to say that there are a number of biomarkers of substance use that Dr. Cook, that many of others in this room have used in research or clinical settings. On the left, there are a number of biomarkers that are excellent at addressing or measuring, capturing short-term use, so breath, saliva, dry blood spots, plasma, urine, with window of detection from hours through days. And then there are keratinized biomarkers like hair and nails, which have a longer window of detection between weeks to months. Again, I'm not really getting into the difference between hair and nails. We talked about it in one of our breakout groups in the last hour. There are, I think, potentially pros and cons of each. I'll say our lab run by Hideaki has not moved into nails as much as Hideaki was telling me just recently. Nails are hard to clean. Matt finds them gross, I'll say. And actually in a really wonderful review that came out in DAD in the past year, they found that particularly with, they were looking at heroin and opioid measurement via via nails. There was some question of whether contamination, like physical contamination with people using their hands, was leading to levels that were higher. Fingernails were higher than toenails. So anyway, so we're focusing on hair. And again, as like a whirlwind tour, I'll say that there is a really fascinating history of using hair as a matrix of detection. Forensic analysis has really been where a lot of this work has been centered. And one of the beautiful parts about hair is that you can analyze samples that have been sitting around for a long time, as long ago as Napoleon. And the compounds that you can find in hair are also quite diverse. So you can see up there, Dr. Cook also mentioned, interest in cortisol levels. At the UCSF Hair Analytical Laboratory, they really pioneered the study of of antiretroviral medication adherence, as the field of psychiatry had also done before. And these slides are borrowed from Dr. Monica Gandhi, as run by Hideaki and Monica. They've really created a again, just pioneering tool that allows for cumulative detection of antiretroviral adherence. And so what does that mean? Cumulative, whereas a urine test, as I mentioned on that first slide, may tell you about the last few days, cumulative collection of hair can tell you about sort of as long as that hair has been growing. So if you cut a centimeter from the scalp, you learn about the last month. If you cut something with long hair, 6 months or 6 centimeters, you can have 6 months. So that's sort of your window of detection, is how far from the scalp you are. And so it's really phenomenal. And many people in this room, including Matt, are just doing fantastic work on understanding adherence and PK based on this hair work. We know that as I mentioned, as this long-term marker of adherence, it's really one of the strongest predictors of virologic response, as makes sense. And in work, particularly sort of profound related to PrEP breakthroughs or people acquiring HIV on PrEP, hair in this sort of time varying concentration can be really helpful for understanding, why did someone seroconvert? I think you can imagine the number of possibilities related to substance use, work in hair, for the completely unacceptable, out of control number of overdose deaths we have in the city. Can we look at buprenorphine in hair and what was their bup concentration at the time of death? What was methadone? What was, can we understand better what protective means? So that, I think that's my brief tour of hair. And then I'll close by sharing sort of two things. One is formative work that we're doing, and then another is a trial that I'm amidst, in which we're using both of our biomarkers. So first, this is validation of hair for, again, this cumulative detection of methamphetamine. And the goal is really, can we improve objective detection of methamphetamine use in people living with HIV or at risk? And in this first phase, which may feel, I think there's many different ways to design this, but in this first phase, what we were seeking to do is, methodologically, can we do this? Can we sort of accurately, or like with validity, find methamphetamine in hair where we were expecting to find it? And so what we did was use the M-study cohort. Dr. Gorbach runs that cohort at UCLA. It's a wonderful prospective cohort of individuals who are MSM at risk of HIV or living with HIV, and who have a number of biospecimens collected over time. And we had, in the sort of first column, there are 22 individuals who self-reported daily or weekly methamphetamine use, but had negative urine testing at the time of that self-report. And then we had 22 control participants who also had negative urine testing and reported no methamphetamine use. It's either relatively young, a relatively racially diverse sample, and the proportion living with HIV differed between groups, and as did the proportion with suppressed viral load, with sort of less optimal suppression in the people self-reporting methamphetamine use. And what did we find? Are simply of the 22 individuals who self-reported daily or weekly methamphetamine use, we found methamphetamine above an accepted sort of DOJ threshold in 77%, or 17 additional individuals. This essentially was a likelihood ratio of 6 for detecting methamphetamine use that was not detected by urine. And then among the controls who had no reported meth use and negative urine tests, 3 had positive hair tests. I think this brings up one of the limitations is we're using self-report and hair. So was this sort of a specificity failure, or was this use that was not disclosed? Sort of suspect the latter, but I can't really say. So I think that the next steps here are to validate the quantitative hair levels, and that's where I'm really excited about the work and really defining, quantitatively, can we develop an instrument that can tell us how much use is sort of corresponds to certain amounts of self-reported gram, a gram year history, or someone describing a certain dollar amount, et cetera, to really define that reduction in use. And then also I think given that that polysubstance use is like more the rule than the exception, I think developing a multi-analyte panel in which you can really understand patterns of use is super important too. So those are sort of next steps. And then ongoing work, we are amidst an implementation effectiveness trial of contingency management for both stimulant use and HIV that's embedded at Word 86. So the goal of this CM program is to support people to reduce stimulant use and optimize their ART adherence using a point of care urine tenofovir assay. So one urine sample with the point of care urine tenofovir assay and stimulant use detection on that urine sample, and then they can earn based on sort of either result, as you can see here. And I think that the urine biomarker piece is super. It's just interesting and exciting to use the urine tenofovir assay. We're collecting hair once a month to understand whether a once weekly contingency management operation is associated with reduced use, because I think you might say, oh, if you're just having people come in once a week, you're not ensuring abstinence, and so are you just missing people, or are people sort of gaming you easily? And so I think in that manner, I'm really excited about sort of testing an intervention that is at least, we need to formally study this, but is currently feasible to do in clinic, or a bit more feasible than a couple times a week CM. And if we can hopefully demonstrate reduced use via hair, that would be fantastic. So that's where we are, data forthcoming. I think one thing that people might be wondering is like, well, how acceptable really is hair collection? How is this going for you? And it has been just incredible. 100% of our participants have given us hair samples. It's a diverse set of individuals with different types of hair and haircuts, and it really is more unobtrusive than I had sort of been thinking. It's also quite easy, I think, as specimens go. The ability to store it without temperature regulation and sort of have it last somewhere is really fantastic. So that piece has been great so far. And I will end there and thank Dr. Gandhi for her slides and mentorship, along with Dr. Coffin and our collaborators at the M study.
Yeah. I had a question. That was really nice. I was just curious, in the study that was done with versus using meth, and in the group that reported use, did you look at any relationship between the amount of use and the quantitative levels measured hair? So not so much a not present, but could it be used as again, just thinking ahead to your commenting on, to use continuous outcomes of levels in essence to see your, I think, very first slide, not an absence model, but a chronic disease care model.
Yes, yeah, absolutely. There are about 85% of the participants had weekly use rather than daily. Mm-hmm. And then the quantitative levels, I think, will be something that is forthcoming once we can Hideaki more sample to more robustly develop the control and then really sort of validate what those quantitative levels are. But completely agree. I think that the goal would be to validate their levels against the sort of, daily, weekly, monthly, never, and look at that more continuously.
I have two questions. One, don't you think that secondhand smokers can affect on your results because they may quit using it, but someone else next to them are using it, and that can affect on your test results? And the second one, how much measuring biomarkers could be actually useful in clinical level, because as far as I know, even if those who are using opioids cut their use into half, still you can have a positive urine test results, but it doesn't mean that they are not trying and successful in their treatment.
Yeah, I think that's such a great point. It both really excellent questions and points. The first, yes, I think understanding, say of those three participants, or say looking forward at other reasons why this test may not be specific. I think that's really a great point to think about. What are other ways of exposure that are not intentional use? I have a patient who reports that she packages a lot of cocaine, and that's why her urine test is positive. And you may wonder, does that hold up biologically? But that's what she's reporting, and maybe this is true, And so I think that's a really great point. And then second, yes, I think this is a limitation of hair in that the way that we are analyzing right now, have capabilities to analyze. It is not, the turnaround time is not really suitable or for clinical use. It's more, I think, applicable at the moment for research use or to consider outcomes or variables in cohorts. But I wish that we had a better way to quantify things. Completely right. I think that's one of the limitations of CM too, is that it's evidence-based.
It seems like you have an opportunity to interject and this more commentary, but not only with interventions, I think of this, but also just with clinical outcomes. When you're trying, like case Phil presented, you're presenting here too, understanding how variations in use might correlate to negative cardiovascular, pulmonary, cerebrovascular outcomes would be really interesting.
Yeah, 100%. The cardiology division at CSFG, they just see so much stimulant-related cardiomyopathy, and I know that there are actually a couple of fellows focused on, they're trying to understand, are there genetic polymorphisms that are associated with who develops heart failure and who doesn't? But then part of that you have to factor in is what degree of exposure, and that I think gets to this point, we need to figure out how to measure it because we can't. Thank you. Should I advance to Dr. Cook's slides? Sure. I have the privilege of introducing Dr. Robert Cook, and here. Dr. Cook is a professor within the Department of Epidemiology at the University of Florida, where he also sees internal medicine patients as part of the Division of General Internal Medicine. He is the director of the Southern HIV and Alcohol Research Consortium and the associate director of the Consortium for Medical Marijuana Clinical Outcomes Research. And his work is primarily focused on improving health outcomes for persons with HIV, evaluation of alcohol intervention in this population, and evaluation of health outcomes related to medical cannabis. In addition to this research, Dr. Cook devotes significant time to mentoring junior faculty, graduate students across many disciplines. And I'm really thrilled to hear this talk and thank him for joining us.
All right. Thank you for having me. Thank you for introducing me. Thank you for the kitties.
Thank you.
And it's an honor to be here on the West Coast. You people. All right, and hello to any of you all on Zoom. So this talk is called Clinical Trials of Alcohol Interventions in People with HIV, Our Experience with Prescription Medications and Contingency Management with Biosensors. So I've got about half the talk is going to be about an naltrexone study we did, but some of the lessons that we learned. And then the second part will be a little bit more with the biosensors. And so I'm going to discuss 3 alcohol intervention trials and some of the design challenges. The data interpretation really overlaps what our previous speaker spoke about in terms of how do you evaluate these interventions in terms of success or failure. And we have learned some tips to support future interventions. So this is just an advertisement for our organization, the SHARC website. You can see it shark-research.org. We do have research training programs, and we really do try to do community engagement. have an open postdoc spot. If anybody wants to do a postdoc, come talk to me. So alcohol, you sort of know about it. I always see the sign and imagine what it would sound like to be walking on a sidewalk outside with your feet sticking to the sidewalk, and maybe your drinks in the alley. Like, what is alcohol as an exposure? So our overall conceptual model is that alcohol or drugs at some point could affect either health outcomes through a behavioral pathway, so it appeals to our behavioral scientists, and through biological pathways. And the biological pathways could involve systems like inflammation or health issues related to the gut or the liver or the brain. But the fundamental challenge, again, what we talked about in the previous talk, is that alcohol is very homogeneous in terms of its own use and how we measure it. And also we are dealing with health outcomes that could be both acute effects, such as driving when intoxicated, or chronic effects, such as effects on the heart or breast cancer or the brain. And when we try to examine exposure, we know that a lot of people drink in the United States, including a lot of people in our research society on alcohol, and it looks hypocritical at times. It's like, is this really a health issue? Why are we serving alcohol at the alcohol conference? So I mean, we do drink, and we like to think that we can differentiate into alcohol use disorders, which for this discussion, I'll just be people that really obviously have problems. I mean, they do have problems. They need intervention, and it's harder to intervene on them because they may need detox and they may not be able to do contingency management. Hazardous use, boy, you can use a lot of different words, but maybe this is at-risk drinking or unhealthy drinking, or this is drinking where we think at the public health level, if we could intervene, especially for these chronic effects, and possibly prevent some acute effects as well. So many people are in that category. Then non-hazardous use, you know, in the last year, we saw several papers coming out saying any alcohol is bad, and we can pick at the methods as epidemiologists, but it probably is true. It's probably not very healthy overall, any alcohol, but maybe the risk is worth the benefit. And then we have non-users that include past users. So sometimes their health outcomes are difficult. But if we could do an intervention that took people from hazardous use or the AUD category and knocked them into the non-hazardous use, would that be good enough? Or do we need to knock them into the non-user level? Or could they just reduce from 90 drinks a week to 45 drinks a week? And analytically, we have a hard time doing that. And if you design clinical trials, you do need to declare up front which analytic method you're going to use, because as Dr. Hahn has seen, actually, we've written 2 papers with the same data set and come to 2 different conclusions about whether our intervention works, because we use different methods or control for different things. And you don't want that to happen. So you should write in advance. So my sort of alcohol HIV journey started almost, 25 years ago. We did a cross-sectional survey, anonymous survey in an HIV clinic. This is my first few years as a faculty member in Pittsburgh. We surveyed people with HIV. Everyone was saying it's probably associated with medication adherence. We're not going to prescribe ART to people that drink because they're not going to take it. But nobody had published proof of this. So we did a cross-sectional study, and we looked at different patterns of drinking. And we looked at taking medication off schedule, which is this middle column, and looked at missing doses, and whether it was binge drinking, which is exceeding certain daily amounts, hazardous drinking, which in this case was a high audit score, heavy drinking, which was maybe weekly limits you exceeded, or any of the 3, you saw that there was various risk of these adverse outcomes of adherence. And then this was the first, but they wanted drugs. I said, all right, I had written a grant to do a brief intervention using video and getting people in the clinic. They were going to do alcohol intervention. And so RFA came out and said, give them medicines. So I was like, all right, I'm a doctor. I can give them a pill. But I'm also at the time relatively junior investigator. I said, we're going to focus on women because that may be a way we can break into this world as a junior investigator, put a slightly different spin. So we said, all right, we're going to design an alcohol pharmacy for women, and we call it Will Having Alcohol Treatment Improve Functioning. We called it the What If Study. And we, at the time, were collaborating with the WISE cohort, And as we thought about our study design, the premise is if we take women with hazardous drinking and do some sort of intervention that we could, hypothesize it would improve medication adherence, improve drinking outcomes, and then we might see improvements in clinical outcomes, which for people with HIV often is viral suppression. But you could think of cognitive function, you could think of liver disease or VAX index, a variety of outcomes you could measure. So questions of the group, the intervention is naltrexone oral, 50 milligrams a day. This was what people were generally using. The combined study had just come out showing that this dose beat placebo. And we like naltrexone because we said, well, people can take it if they're drinking, that we don't really have to worry about withdrawal as much. The main reason people can't take naltrexone, you may know,
Liver enzyme elevations is sometimes.
Heroin.
Using
Heroin
opioids.
withdrawal.
all right, using opioids is the big one. So we didn't want to give naltrexone to someone opioid, we put them in opioid withdrawal. We did exclude people with elevated liver enzymes, which does require you to do a blood test before you start them. And then pregnancy was another one we decided we would enroll pregnant women. But we said we'll enroll them if they're using drugs, we'll enroll them if they're mentally ill, up to a point. These were going to be difficult people because, those of you working in HIV clinics know that and the combined study excluded all these people. Like if you have serious mental illness or you use other drugs, we're not including you. It's like we want to do a real world study. So I wanted to say, look, these women aren't getting any intervention. Let's give them naltrexone and compare them to usual care. And the grant reviewer said, placebo-controlled trial. I was like, we already have data that shows naltrexone beats placebo. Not in this population, not in people with all these other comorbidities, and we don't know if it's safe. So we said, all right, we'll do a placebo-controlled study. And we also thought we were innovative because we would do it within the WISE cohort. So the WISE cohort's already tracking clinical outcomes over time. The WISE cohort avoids the issue of people lying about drinking to make money to be in a research study because they already answered questionnaires as to whether they drink or not, independent of any incentive. So we could enroll people who already said they drank. We've already got a research structure in place at these WISE settings, and we can follow them up. And WISE agreed to let us do it and gave us extra money, but it just turns out to be a lot of work to run a clinical trial. And it's more work for the staff than we all think. But we did it. We enrolled 17 women we had like a 2-year study. We also did it in Jacksonville. And in this particular graph, the y-axis is the mean number of drinks per week. So mean number of alcohol drinks is tricky because there's a lot of extreme levels. This is, again, drinks per week is even tricky because is that drinks over 4 weeks averaged or literally the last 7 days? We actually tried to do a 90-day timeline follow back. That was what my advisors told me to do. Gosh, but as you can see, it looks like naltrexone in the red there did a little bit better than the green, but it started off a little bit better. But this graph is going to look very similar. We gave drug for 4 months and then stopped it and then waited 3 more months. And interestingly, you can see very little rebound after we stopped the medication. And the outcome is self-reported drinking. So we did learn it was hard to enroll people in the study. If you want to recruit women with HIV who drink, it is difficult to find a lot of them. We did conduct a study within the WISE, but staffing needs were high. Nevertheless, we did try to do it in WISE again for the next, and for a variety of reasons, we're told to move to Florida, which I'll tell you next. But in Jacksonville, it was interesting. Women did not want to participate in the study. And the staff told us that they just either said, I don't drink that much, I don't need to be in a study of drinking, or I don't want to quit drinking. And then there was a lot of overlap with the opioid use, but just reluctant in that particular setting to engage in an alcohol treatment study. And the staff thought it was just stigma to be in the study. Then this came out. This was 2011. You can apply for you can submit 3 grants together and try to become an alcohol consortium. And I did submit a grant with the WISE cohort. And one of my studies got well-reviewed, one didn't. And the NIAAA said, if you'll partner with this group at Florida International University, we'll give you guys a lot of money. If you don't want to partner together, you don't have to. And like the IRB consent form says, and you don't have any money. So Shark was formed in 2012. There's Kendall Bryant in the middle. Maria Magaz was the leader at FIU. And we had a biostatistician, Dr. Brumback, and Seema Desai was a basic scientist at Rush who was going to look at alcohol and immune function. And so that was our Shark. The study design was a randomized trial. Basically, we were going to enroll women with HIV and hazardous drinking. They'd be randomized to treatment or placebo. 4 months was going to be the main outcome. And I believe we defined at that point, the main outcome was either they're hazardous drinking, yes or no. We decided a categorical outcome. And then let's see what happens at 7 months. So they had to meet just the minimum hazardous drinking to get in. And again, if you want to do an alcohol intervention and they're just barely exceeding, there's not a lot of room for improvement. But we had some women that said they were drinking what we calculated as 300 drinks a week. My biostatistician said she couldn't believe it. And again, we were debating what do you do with this data point of 300 drinks a week. Self-report's tricky. They were excluded if they were opioid users, pregnant, elevated liver enzymes, and investigator concerns. And I was often more willing to leave them in the study because I was, as a primary care doctor, I was like, I would give them the medicine, see what happened. But fortunately, my colleagues kept certain women who were probably shouldn't have been in the study out of the study. So this question for you guys, should we have required positive PEth at baseline as eligibility criteria? There was another study done at Johns Hopkins by Betsy McCall and Gitanjali Chander, who they had also been funded to do women at Johns Hopkins, and they were going to require PEth to get in their trial. I decided not to because it is logistically challenging to confirm the PEth level and then start them in the study. So it's going to be a delay. In retrospect, and it probably would have reduced our enrollment because only 50% of the women we enrolled had above an 8. So some of them had a subclinically positive, but a lot of women.
Tell other people what PEth is.
PEth is a biomarker that is in the red blood cell lining. It's I can't say it, it's got a phosphorylate on an ethyl. Can you say it?
Phosphatidylethanol.
Phosphatidylethanol, phosphatidylethanol. But anyway, it's a marker that does appear to be present only in the presence of heavy drinking. There's very few false positives. False negatives, we had a lot of people that had a negative PEth that said they drank and they were going to earn a lot of money to be in our research study and they were going to succeed.
Right.
And there was a talk at the NIAAA that really talked about this challenge in clinical trials, that if you enroll maybe 20% of the people who really don't drink, you will not get statistical significance in the end. And so if you do alcohol trials, you really want to try to find a way to confirm that they're drinking and self-report. And self-report is what the combined study did. Almost all of our alcohol clinical trials are self-reported drinking. And we did really good self-reported drinking in the study. We had bottles and glasses, and we had lists and did our best to do a good timeline fallback.
Quick aside, not to say that you can't game this too, but we used urine ETG as along with audit C as a way to.
In our next study, when people said they didn't drink and our biosensor said they did, we gave them the ETG as a way to break the tie. And we collected all the ETG. So we published the results of the What If study. This graph shows the proportion of people with hazardous drinking. So everyone had it at baseline. At the end of the study, as you can see, both the placebo and the naltrexone group had reduced to less than 40%. At 2 time points, the naltrexone women reduced faster. But at our primary endpoint at 4 months that we declared a priority, there was no statistically significant difference. This is consistent with what you see in the literature. Naltrexone does a little bit better than placebo. But boy, those placebo women did well, or they weren't drinking. But they couldn't have all been lying. We think they did well, and we did say, well, did the women who quit or reduce have better health outcomes than those who continued drinking? So there's some bias in this type of study design, but it's reassuring to see that in the red line, that's the percentage of people with suppressed viral load. The red line is the people that quit or reduced drinking by 7 months. And the blue line is the people that continued to drink at 7 months. And you can see that the women who quit or reduced drinking had better outcomes than those who continued to drink. And we had 85% follow-up at 7 months. So the same reason I think people did well with placebo is the same reason that we had good follow-up, and that's that we had really good study staff. You should picture study staff at a party with their babies, but this study staff was nice to the people. They asked about their children. They called and see how are you handling the medicine. They were trained they were trained hard. Do not flinch if they say I'm successful or failure. Just, don't go, oh, good job, or oh, I'm so bad. We want to minimize the self-reported bias in terms of the number of drinks, but later we did qualitative interviews, and I think I have that. This is just one side note, and so we do have somebody that are the addiction specialists. So just treating pain with alcohol affect drinking reduction among women with HIV enrolled in a clinical trial of naltrexone. So we asked the women at baseline, do you use alcohol to treat pain? And 30% did, and almost all of them said it was effective. And we do have pretty good evidence that alcohol can treat pain, both. And I would say our women didn't always differentiate physical pain from emotional pain. It's often very interrelated, but the women, about a third, use alcohol to treat pain. So do you think naltrexone works differently in women who use alcohol to treat pain than those who use alcohol to treat pain? Because naltrexone blocks a mu opioid receptor, which probably has something to do with pain, and alcohol hits that receptor. So my PhD student Christina did it. This is now we're back to mean drinks per week being plotted, but the black line at the bottom there is the best. They quit the fastest, and that is not using alcohol to treat pain and getting naltrexone. And the women that did use alcohol to treat pain sort of did the same as the placebo. So they also tended to have more problems overall and maybe higher audit scores, but it is interesting to think that there could be subgroups of people that would respond better to treatment than others.
These y-axis measures, this is all reported, self-reported.
This y-axis is all self-report.
Bob, for the what-if study, what's the adherence to naltrexone?
So the adherence to naltrexone or placebo, we did measure. We had them use blister packs of pills, and they brought in the blister packs, and we could count them. And it was about 70% for both naltrexone and placebo. They really kept taking it unless they had side effects. We had, the combined study had this medical monitoring counseling part. And I was also saying, that's not real. People don't get this. But you'd call them at 3 days and they say, oh, I feel nauseated. They say, oh, we'll take it at night. So we were giving them a lot of advice on how to encourage them to take the study medication. And I think we do have data on what people thought they were taking, but I think most people thought they were on a naltrexone. And they would tell us it was helping them not drink because they would think they would get sick, which wasn't necessarily true, but it was a reminder they were trying to do something. Right. And what I've learned here is something about this trial really worked. And so if we just offer something and we monitor people and we give them feedback, and I do think that a lot of women enrolled in the trial because they did want to quit drinking. This might have been a strategy to help them do it. But it still really was successful. If we did look at PEth levels, which didn't correlate very well to individual alcohol self-report, but the naltrexone group did have a better decline in PEth levels compared to placebo on average. The naltrexone group also reported significantly more nausea than the placebo. So the cynical side of me said it made them sick and that's why they drank less. But we had one person have a subarachnoid hemorrhage. We had one person die. We had another person admitted to the hospital within 8 hours of her first dose of study medication and acute renal failure. It was a difficult study population. We had a good data safety monitor board that looked into all this. We never concluded that the medicine hurt anybody, but you always do worry about that. So this was what our previous speaker also talked about: reduction in drinking versus complete cessation of drinking on the severity type of alcohol-related problems in women with HIV. So Veronica Richards was a PhD student. We did the short inventory of problems. It's 15 questions, and we changed it sort of yes or no. When you drink, do these bad things happen? And there are 5 subscales. And at baseline, we measured them, and then we measured them at the end of the study. And we said, will there be a bigger reduction in, or no change in alcohol problems if people quit drinking completely versus reduce drinking versus continue heavy drinking? The last slide from the study, it's complicated, so let me walk you through it. Change in SIP score. So the SIP domain scores on the y-axis, and they could go up to 3. So higher is worse. The dark bars are baseline scores, and the light bars are follow-up scores. So most people had reduced problems at follow-up. But then for each of these 5 domains, physical, interpersonal, intrapersonal, impulse control, and social, we said, what's the change in people who quit drinking, or the change in people that reduced drinking, or those that continued heavy drinking? And for almost all of these, you can see that if they quit drinking, there was a pretty big reduction in SIP symptoms. And if they reduced drinking, there was kind of a medium. And if they didn't quit drinking, there was really relatively little change. So it could be with the way some of the questions are worded, that if you drink at all, you might get a score, but this does suggest that possibly quitting drinking is better than getting below the threshold. So we wanted to get renewed, and IAAA said we don't want any more naltrexone trials. We did have some new collaborators. We wanted to extend our work to neurocognitive and neuroimaging research. We were interested in biosensors, and we also wanted to look more at some of the mechanisms of change. So people quit drinking where their body improved. Do you have a question?
Oh, no, just for later.
Yeah.
Yeah.
All right. The title of this grant and the number of co-authors is going to tell you one of the problems with this particular study. All right, experimentally induced reductions in alcohol consumption. All right, so we're gonna make you reduce your drinking, and we're gonna study brain cognitive and clinical outcomes, and we're gonna examine older people with and without HIV infection. We wrote a grant, said we're gonna do it for 30 days. The grant reviewer said that's not long enough. Do it for 90 days. I said we don't have enough money, and people aren't gonna wear it. We tried to do it for 90 days, and now, but practically we needed to cut to 30 days. And then we have a lot of people, and basically this premise of the study was that alcohol, at the very far end will affect HIV behavior outcomes, but it will do it through these mediating pathways, the gut microbiome and the liver, and through these brain pathways that we can measure both with cognitive testing and with different types of brain neuroimaging. So 3 or 4 different types of MRIs, functional MRIs, diffuse tensor imaging. Yes.
What was, it said you enrolled older individuals? What was the age?
Well, we wanted to enroll, 50 is the answer. I think we might have reduced the age at one point because we just wanted to get more people in the study. But we did, I think the average age is in the 50s, and they're mostly Black people that enroll in the study. So we put an alcohol biosensor on them, which I'll show in the next slide. And if they kind of qualified, we would pay them up to $400 to not drink any alcohol. And it wasn't to see whether contingency management works, because again, other people have shown that contingency management will work while we're paying them. But we wanted to see, would reduction in drinking improve all these body functions? So then we said, all right, after we stop contingency management, what will happen? Will they resume? And that could be a second research question. So this is me at a good old Gainesville football game with my red Solo cup. I might have fallen maybe on my face 3 steps later. You never know. But you can see there's this gram alcohol biosensor. So I wore it to the football game to see if anybody would say anything, to see if. But our patients did say, listen, we live in my neighborhood, when people are wearing that biosensor, people judge us. People think that we're in jail or something. And they're in Miami. So they're like, this study was in Miami because we needed to find a lot of people with HIV who drank. But we did try to do qualitative interviews, and I worked to sort of set up what would people want and sort of this contingency management intervention. And they basically said a lot of money. So the next time we did this, we asked them more about what features of an intervention would they like. But these biosensors, self-report is challenging. They are designed to objectively and continuously measure alcohol in a natural environment. They use transdermal sensors, which can detect the 1% of alcohol that is excreted through your skin. And they produce transdermal alcohol concentration readings. And I do have a graph I'll show you in a minute. This is just the bottom line for our 30-day challenge outcomes. COVID wasn't our friend either. But we did enroll 57 people with heavy drinking who met all our criteria, initiated the protocol. Their mean age was 56, 63% male, 77% Black. And most of them completed 30-day follow-ups. Most completed 9-day follow-ups. The gram sensor was not popular. They nearly all reduced drinking. And we really didn't know how to measure reduction drinking with scram yet, but you can see fewer curves and many analyses are in progress. We did have a few people challenge us. You can set the sensitivity or specificity of a scram to get fewer false positives or false negatives, but it's not perfect. If you spill alcohol on it, we had one guy working in a bakery and there was yeast. Do I need to stop?
Oh, no, I was filling gigs.
All right. How many good time? I've got about
You have
10
a
more
lot.
minutes. So Veronica, one of my PhD students, so we were going to move to the next study to say, all right, let's move to a wrist-worn biosensor. The problem with wrist-worn biosensor for contingency management is you can take it off. The scram is locked onto the ankle and you can't take it off. And you have to take it off to charge it. Also, the scram has been used a lot. It's been validated enough that law enforcement could even use it. You could even be put in jail based on its results. With the wrist-worn biosensor, and we didn't know for sure how accurate it is yet, but it does use similar technology. It's just on the wrist. And Veronica and them interviewed people. Half of them were in our 30-day challenge study and half were just adult drinkers. They were older people, and she wanted to know what are some features that would be acceptable and helpful in an intervention that used a biosensor. And these are some interesting answers that could be helpful. So 5 themes. Things that would influence people's willingness to use a biosensor could be general thoughts about general features like how it looks, is it comfortable, is it easy to use, easy to put on, and we've got flowers on it. The new one looks like a watch. Personalized messaging they thought could be useful, and this is something we're still thinking about. Could the biosensor give them text, or could it send them information and say good job or bad job? The preference for the time wearing the biosensor differed depending on the drinking goals. If people wanted to quit drinking completely, they thought wearing it all the time was important because they wanted a permanent barrier to drinking. Whereas people that just wanted to cut down thought they only needed to wear it when they were going to go out drinking. People had mixed opinions about sharing data with others. You can imagine it could be an effective intervention if you say your sponsor in AA is going to see this data, or your doctor's going to see, or your wife is going to see this data, versus if you keep it private. So people had different preferences. And then surprisingly, many people said, how is it going to help me with my mental health? How is it going to help me with my mental health? And they really talked about the overlap of drinking and mental health and suggested that just a isolated drinking intervention might not make sense. Why not combine it with a broader intervention? Does it work? So my colleague Yan Wang got an R21 to validate the skin sensor. We brought in 40 people, including some with HIV, to see. And the VAC study suggested that people with HIV could feel a buzz with fewer drinks compared to people without HIV, suggesting maybe alcohol metabolism could be different. So we would look. So they were going to do both fixed lab administration with 3 beers in a row, and this drinking lab. They also did a field validation where people went out for 2 weeks and wore the biosensor and kind of did self-reported diaries which we're going to do again pretty soon. The Backtrack skin this is what it looks like now. Its wrist sensor only has an iOS app, which only works on iPhone at the moment. It measures transdermal alcohol consumption. It measures motion, so you can kind of tell people are using it, and temperature. So in theory, if they take it off, you see a change in the temperature, and if they put it on someone else, even you would see a temperature. It is waterproof, which Scram is also, but not. People weren't supposed to go in a swimming pool with a Scram. Battery life of a week, which is better. It used to require 24-hour charging, but it does have to be charged. And data transmitted in real time to a research portal, but that's through Bluetooth, and also then Bluetooth getting uploaded to a cloud. So again, a lot of our people in Miami, if Bluetooth isn't working or it's not connected, and they don't have iPhones in the first place, they're having a lot of challenges in this kind of technology. And sometimes if they're not in a place with Wi-Fi, they can say they were in a place with that. We can say, oh, we don't know if you drank or not. We're doing contingency management. We need to see your data. And they're like, oh, no, I was offline. This graph is from a real participant. They gave him 3 graphs. The red dots are breathalyzer readings, and the blue lines are transdermal readings. The scales are on the different sides of the graph. So the breath alcohol concentration is on the left side, and the different units. So they don't correspond exactly. And I think there's some legal issues too that Backtrack's nervous about in terms of whether its device can truly measure breath alcohol. Because if it can, there's some legal stuff that comes up about could it be used in court and stuff. But you can see that even with this fairly nice curve in the blue, we humans can kind of see the pattern. But if you ask the computer to read it, it's just got a lot of this, any single time point is what the Scram sensor does is average these over like 30 seconds and give you a reading. But the skin is not doing that yet. And there are people involved. Brian Cephalot is one. They're trying to write machine learning to sort of analyze these curves. But again, we compare self-report to some of these curves, and we say what we think is right, but we don't know. So it is hard still if self-reported drinking is what we can compare it to. So, and there can be false positives from environmental interference. We do need better algorithms for determining both drinking episodes, yes or no, did they drink at all, which is kind of what contingency management versus, how much did they drink, which I'm interested in because all of these people down the same row of the table could drink 3 drinks, but have very different effects. A hypothesis could be that the peak TAC might help differentiate or correlate with your self-reported intoxication, or actually your observable functioning, if I could have that data, which other types of sensors like your cell phone could have. With accelerometers, we could see if people can walk straight lines or type clearly, or whether they're stumbling with their typing, or even speech will change. So there's a lot we could do to measure functioning in real time with these types of data. Thanks to Yan Wan for some of those slides. 4 slides left. This is getting you caught up to date, 2019. Instead of the U grants, they said we're gonna have P grants. And I know Dr. Han's got one of these too with all the Uganda team. And then there was an R01 that came out that we applied for, where we said we would do more implementation of biosensors, and at the last minute we got that one. So the PO one, we said, all right, we want to not use a Scram. We're going to try to use the skin. We're going to try to move toward implementation and figure out, would people use this in the real world? Can we make it more fun? We want to enroute. Now it's 80 people. It started with 120 in 3 arms. We just now have 2 arms. Middle-aged, moderate to heavy drinking. Dr. Lehman excludes them all if they use drugs and are too mentally ill. I argue with him, but we have arguments about who's to say. Everyone gets contingency management 30 days, but they have to blow in a breathalyzer, which I even worry about the security because I see the person, you see their face on the screen, they get a geolocation where they are. We can see where these people went. I'm like, seems like private information. Backtrack has information. And people have said that there's just times it's not cool to blow out a breathalyzer. For example, let's say I had to blow in one right now. You guys might I'm blowing in a breathalyzer. The skin, second month, we're going to use just the skin, trying to pay less but make it more fun. So far, people are like, why aren't you paying me as much? And we also, are not competing with the video game industry, making it fun. I think the fishbowl you saw with, different stars, that looks more fun than what we've got so far. So there's room for improvement. Fortunately, this is still sort of idea generation, but I do think people might do something fun and competitive if they want to do dry January or damp January, or if they want to do sober October, or if they want to kind of compete with other people. The other clinical trial is called cognitive inflammation, targeted gut-brain interventions in people living with HIV, high-risk alcohol users. And this is to try to kind of protect the body from alcohol using either vagus nerve stimulation or probiotics, which are supposed to replace your gut microbiome with good bacteria. And they give various combinations of each. They're not really doing a drinking intervention in here per se. We're doing brain scans again. And the idea of the vagus nerve stimulation is kind of interesting. And, in theory, if you're really stressed out, or it maybe would help calm you down. But we're just giving it at a fixed time. And again, technology is challenging, but it's going to be an interesting study. And then in wave 4, the Florida cohort, we are going to enroll about 80 people. It's called Technology-Based Assessments and Intervention to Reduce Alcohol and Improve HIV Viral Suppression in Florida cohort, identify barriers and facilitators to achieve ending the HIV epidemic goal, and also incorporate technology-based alcohol interventions into clinic and community-based strategies. So how would we incorporate these interventions? How would they ever get used in the real world outside of a research study is something that we're really trying to figure out. Is could we integrate these into Ryan White programs? Could we integrate them into Dr. Ingersoll here in the middle created something called Positive Links at the University of Virginia. And she's published some stuff at this mobile app that has both a support kind of arm for people, kind of community support arm in the app, but also increase access to the clinic staff for appointments and medicines. Their clinical trial showed it was popular and reduced, had increased adherence and I think reduced viral suppression. And various people are using that app, and we were thinking we could incorporate it into some existing, how do we incorporate the alcohol intervention into sort of existing interventions? So we're going to have a community advisory board that's going to meet next week across the state, sort of experts tell us how the mental health and substance abuse and HIV system could be better, how we could integrate alcohol interventions. We are collecting just survey data, and then we are going to have about 80 people wear the biosensors. I think that we also can collect different pattern data than we normally collect. So the timeline followback says how many drinks per week, and you could even get how many drinks per day, but it doesn't give you that sort of intensity of potential like 3 drinks in an hour versus 3 drinks over 4 hours, or I don't know, maybe more direct correlations with some of these things like hangovers or self-reported intoxication. So we will see. And here is our 232 training program. As I said, we got nursing faculty in there, we got nursing students in there, we got health behavior students, epidemiology, clinical psych, palm trees. That's the end of my talk. Thank you guys for coming.
Thanks.
Last week. Where did you see him? I said, wait up.
We have a few minutes for questions for Dr. Cook.
Actually, maybe 2. I just don't know a lot about these what do you call them, the skin sensors? Like how do they work? What are they measuring? Is it like salts? Is it sweat? Is it?
So it actually is alcohol. So alcohol is in the vapor and not in the sweat. So it's in the air. And the sensor is a electronic fuel cell that is powered by alcohol. So if alcohol hits the sensor would produce some type charge, and that charge is what gives the signal. And so it will also be positive, I guess, with wet alcohol that spills on it. But the vapor, Veronica kind of looked to see, just a thick, with like race or gender or body fat or any of that influence, like individual variation. She did find that people with liver disease seem to have different levels of transdermal vapor. But yeah, it has to sort of be in the right spot. If it's too far away, it may not sense as well. I wore it once playing ping pong, and it gave some very erratic measures. Possibly, I'm not sure why, but the answer is vapor. Alcohol is the fuel, and the sensor is fueled by alcohol.
Okay, no, thank you for that. I just didn't know. And then the second question that I had was, it seemed like maybe the what if study, there was like some sort of like an intervention effect, like your staff were so great and sort of, giving participants attention and what they needed to be successful. Do you think that will be different once you go to like a virtual option of, whether this online version you've created is going to be different?
Yeah, well, so we did do qualitative interviews, and actually I challenged, it was a PhD student. I said, can you figure out we were going to interview maybe 15 to 20 women after the study was over. And I said, ask them if they were lying. And she said none of them would admit that they were, had been dishonest to get into the study. But many of them commented on the social support from the staff that was helpful. Many of them did say just the pattern of taking that pill every day was kind of a reminder of why they were doing the study in the first place. Relatively few said it was just the money itself, but the staff did come up. Other people, I think, just said some of the assessments, where you answer questions like 15 sip questions. When you drink, do any problems happen? And people become more self-aware. It's like, oh, that's true. I really don't think about it. But when I drink, yeah, I do tend to do that more, or get into more fights or more arguments. So I think that also helped.
Like reflective.
But I'm really stunned by the effect after they stop the medication. With the contingency management, we do expect to see a rebound, that once you stop the payments, so it could be the motivation is different too, that people were more motivated to quit drinking and enter this study, whereas contingency management, maybe they just want to get the money and after the money's gone. It could have been 4 months. A lot of contingency managements are 30 days and they don't work. So again, with our less is more study, we're trying to see would 60 days work better, but we are having a difficult time with some of the practical aspects of the technology at the moment with this particular population, many of which are close to homeless and often are just trying to make money to be in a research study. But yeah, I think the staff can do a lot. I think that it changed my mind that whereas I have been a little skeptical of alcohol medications because they really do just give you a little bit better than placebo, but maybe that's because the placebo does well and they're taking a medicine. And do you have any comment? What did you learn in your study with placebo?
So we found a significant effect, but the dosing that we explored was as needed event-driven dosing. Right. And so it might just be different because the timing of the medication is like when people anticipate heavy drinking, and it might also be more manageable for people to kind of anticipate those events. Like, people have like that window before they go out into a bar or meet with their friends. And we found that compared to placebo, the naltrexone group had a significant reduction in number of drinks and number of binge drinking days when told to take it as needed.
And could you tell whether though taking the placebo was better than not doing anything? I
guess we can't, because we didn't have a third. Yeah,
you might be saying, right, I'm not going to drink as much because I'm taking this pill or something. I don't know.
We do think there's that mindfulness that's associated with pill taking, right? That they have to physically put the medication like in their bodies, and that reminds them of the things that motivated them to be in the study. Oh, worried about my alcohol use. I want to cut down through all these issues. So that was something that we thought might be an issue too.
Any other thoughts about placebos? And a lot of people think medical marijuana is a placebo. And again, but they all say, but then, and in the placebo trials, it doesn't win the way we measure things, sometimes with pain. Although anecdotally, we hear all this benefit. So again, whether it's a placebo or not, sometimes I wonder, are we too uptight about placebos?
Right.
Yeah.
It doesn't matter whether it's placebo.
Right. Yeah, that's true.
Probably the culture does affect, because in some cultures, I do believe that. I mean, some cultures believes that when you go and see a doctor, you have to get something from the doctor, that tangible, like a pill. So in that culture, if you do not provide anything to them, that they are not very satisfied with your service, and it does certainly affect on the outcome. And by the way, I do have some couple of questions. One about the motivations that those who are being recruited in the study, besides getting paid, for really want to quit alcohol, or they just want to cut down. This does not affect on the results you are getting. I mean, you do randomization. You are thinking that may level this up between the different legs, but still you may have some imbalance in regards that may somehow affect on your results, even if you are doing correctly based on the protocol. And the other thing is, what's your doctrine about alcohol dependency? You're thinking that it's a pathology in the brain, or it's just a behavior? Because they are saying that those who are their doctrine is a pathology in the brain. Basically, the intervention should be abstinence, not reduction. But if it's about the behavior, so you can cut down and you can control it.
Mm-hmm.
So what do you think about these two? I mean,
well, I think in terms of I've seen people in the hospital that couldn't control it. Yeah. Well, maybe they could. I mean, everyone likes to think people can control it, but if they have one drink, they just couldn't stop. Allegedly, my grandfather was that way. My mother was very worried about me. She said, your grandfather, my father, would start drinking and he would disappear for 3 days. We wouldn't know where he was. This is before cell phones. So every time she saw me drink, she's like, your family is out. I thought about that, but yeah, allegedly he couldn't stop. And of course, he worked in as a nightclub musician, and that wasn't helpful. But so I do think that some people can't stop and they need to not drink at all. I told some of you this, that I'm doing what I call moist January is not the right word. Not dry January, it's not moist, but it's damp or damp January. So yeah, I'm trying to reduce my drinking so I'm consciously aware and trying to set a goal. And the reason might be because I want to lose weight, or maybe the reason might be because my family thinks I'm drinking too many beers, or maybe the reason is, but it would help me, I think, to have an app to kind of track it, because I did lose track and didn't count right one week. I think that we did collect data at the beginning of the study on whether people thought they could quit drinking completely or thought they could reduce. But I don't know if we asked them if they wanted to. But I do believe for drinking that it is two completely different decisions. Do you want to reduce drinking versus do you want to quit? And there probably is two different types of interventions. Just like people saying wearing the timing of the skin would be different if they wanted complete abstinence versus if they didn't. I know with Dr. Han, Judy over here, we get it into, do we want to differentiate even light drinking from heavy drinking as researchers? Because we do want to reward people to go from heavy to light. And in our study, the analytic plan for the 30-day challenge does take into account if people reduced, could we see some improvement in brain functioning versus if they quit. So it's more of a continuous model, but unfortunately with a small sample size. So yeah, I do think that we should, as researchers and scientists, measure whether changes or a partial reduction gives you partial improvement. I do believe in the harm reduction model of substance use, that less is better than not cutting back at all. But I don't know whether people were motivated just to reduce or to totally quit in this study. A lot of people said it was hard because they do get in these social environments. Like one person said that they failed when her husband had people over to watch the Heat game. So it's hard to quit smoking if everybody else around you is smoking. So I think that the environment and the health outcomes could be very different if people are drinking to self-manage this chronic pain or self-manage their mood versus if they are drinking because the 49ers are playing a football game and celebrating. So that motivation for drinking, I think, is also seems to be associated with a lot of our health outcomes. One of the challenges, chatting here, one of the challenges we found in our data with cross-sectionally, we asked people about the benefits of drinking, and we asked about positive consequences. There's a PCORI measure, some promise measure, positive consequences of drinking, and then there's also negative consequences of drinking. So the positive consequences are, do you disagree? When I drink, I feel more confident. When I drink, I feel more comfortable in a crowd. When I drink, I have a better time. When I drink, I feel this, a lot of positive consequences. And the SIP is like the negative consequences. And we found that the people with the most positive consequences were the same people that had the most negative consequences on average, which makes alcohol intervention difficult, right?
Yeah. Question for you, which is thinking about, because you're a clinician also, so, just the way clinicians are trained, right? We're not trained to talk about decrease. It's like, stop doing it. Doing it, stop. I mean, it's sort of like what kind of data do you think could support a change in the way that we practice that says decreasing could be helpful? But I don't even know the question I'm asking you, but the level of data that would be needed, because I think about this a lot in terms of clinical training, because I think it's just easier to train people to say, not good, stop it.
Anecdotally, and what I've seen and heard, both from people who went to their doctor and what did your doctor tell you, versus what I see is one of the challenges is just inconsistent agreement on what the cut point should be. I think clinicians are pretty comfortable saying you shouldn't drink more than 10 a week, or you shouldn't drink more than 7 a week, and people can hear. I think that my doctor said I shouldn't do more than blank, so I won't do more than twice that.
Yeah. Right.
Maybe, but I think they hear that message. I think clinicians are good at setting, certain bar of how much is safe, and we just have different lists. And now we have more evidence saying maybe all alcohol is harmful and stuff.
Right.
But clinicians don't know much about the intervention options. They might have heard of motivational interviewing or brief interventions, but we've seen in clinical trials that clinicians usually, even if you train them, are just not going to do it. But people
It's
seem
changing
willing
over time, though. I mean, that was my training. It was very MI, brief intervention oriented as a primary care resident. So it feels like it's
Some clinicians do it.
Yes.
Those are good doctors.
Right. I mean, I think they do, but
It
it
is
was, when I was working in Mozambique, this was one of the most entrenched things that was fascinating, which was the alcohol thing. Because people would actually say in clinic, and they're stressed for so many reasons, but like, you don't get antiretrovirals if you're going to drink, or if you're going to drink, don't take them. Like, and that was clinical advice. So it was like, it's just an interesting problem, I think, because judgment falls into it too.
I still remember I worked at an STD clinic. Part of my K was work at STD clinic and get training there. And I was measuring, drinking, and we ended up concluding that there were more substance use disorders than STDs among people in STD clinic, but I still remember that the nurses that work in the STD clinic are often not very well paid, and so. But she's like, "You don't drink, do you?"
No, right, that's exactly, that's absolutely right, that's absolutely right. I know.
Yeah, and then again, one of my social workers was telling me, oh, that patient fired so-and-so because he does too much motivational interviewing. So some patients really don't like it.
I think most patients probably are not truthful of what they tell their doctor about how much they drink, but there might be a correlation between.
The limits are probably also based on self-report, right? So,
But I think they can hear. I think they can hear a recommendation.
Give them a
And I know
number,
I didn't.
give them a
'cause-
number,
Yeah.
give them their HbA1c.
We did think that in our research, if we could actually show people that their brain was inflamed, or we could show people that their liver enzymes are elevated, that potentially would motivate individual people.
Right.
Because a lot of people say, well, yeah, I'm included, yeah, that's a good number for the average population, but not for me personally because of something in my mind that tells me I can do it.
Yeah.
But if if there is physical evidence, or we could show you benefit, look how your body changed when you quit drinking. Look how you lost weight, look how.
the problem with inflammation is I feel like the patients who have inflammation have such bad use disorders that it's hard, it's like you need something a little earlier than inflammation.
And I was telling the biosensor group earlier that, using sensors or objective measures of marijuana or cannabis is also really challenging, other than just sort of a yes, no. Do they have any THC in their system in the last 2 or 3 weeks? We can measure with the urine test. It's an area where, again, to study the long-term effects of cannabis, which could have health benefits or harms, or some of each. Just need better measures. So for all our epidemiologists, Dr. Gorbach's a good measurer. She's a good epidemiologist. So pretty good to have her. Smart cookie.
This is a great inflection point, and yeah, I think the next segment is ESI mentoring session. In that I guess phase, we want to center the questions and comments of ESI, and yeah, give them an opportunity to ask Dr. quick questions. But yeah, I guess we can give them a round of applause, and then maybe take a 5-minute bio break. Thank you to the Zoom folks.